allow me to introduce Richard Colley. Richard is Director of Sales for Cardinal Health and has enjoyed a successful career spanning 20 years in various roles, including hospital sales, retail independent pharmacy sales, and is currently in the alternate care division. Since 2012, Richard's primary focus has been on long-term care pharmacies, including assisted living, skilled nursing, and other closed-door specialties. Last year, he successfully launched the Retail Combo program for Cardinal Health. Richard's other responsibilities include managing the relationships with group purchasing organizations. He is also an active participant in the Senior Care Pharmacy Coalition for Cardinal Health. And with that, I'll turn it over to you, Richard.
Thank you, Tracy. Welcome, everybody, and good morning or good afternoon to wherever you are. It is a pleasure to be asked to be a part of the virtual CE program for AAP. Originally, I was excited about attending the CE courses in New Orleans, as I'm sure everybody else was. With that, let's dive into the content of what we're going to be covering today. I wanted to kind of outline the course description and the learning objectives. The course that we're going to be covering today is going to cover all the aspects of the business that you'll need to consider when you're considering a retail LTC combo for your pharmacy. We'll outline the differences between retail combo shop pharmacy and a closed door LTC pharmacy. What types of services will you be required to provide to be eligible? And what are the differences between buying groups and group purchasing organizations, otherwise known as GPO'S? We'll also touch on the financial opportunities and the risks associated with having a retail combo shop. Lastly, we'll also help you evaluate your financial opportunities in servicing these LTC patients and how to mitigate any of the potential risks as you navigate this program. To start, let's start out with what is the definition of a retail combo pharmacy. And for the purposes of this presentation, or CE, a retail open door pharmacy is servicing eligible patients that are in long-term care facilities. The purpose, or we further define those facilities later, but it is important to note that the retail pharmacy is servicing a limited amount of patients to begin with, and is looking to add value through increased reimbursements and brand discounts where applicable. The combo programs, as we see it, isn't an LTC marketing program, but more of an assistance program for pharmacies currently servicing LTC patients. These pharmacies are operating under one State Board of Pharmacy license and DEA license, and isn't ready or interested in incurring the additional costs of going fully closed door. Some of those additional costs would be a new pharmacy location, a separate staffing model to manage that location, a new pharmacy system or other operational costs, as in automation to dispense, or additional marketing personnel and costs. Next, I wanted to kind of provide an overview of what the LTC marketplace looks like. In the top portion of this slide, we're outlining the long-term care pharmacy customer. And on the right side of that, we're outlining the nursing homes settings that they service, primarily skilled nursing and assisted living facilities. Additional services, or the non-traditional settings, are mental health clinics, developmentally disabled facilities, along with hospice facilities, and correctional settings fall into this category as well. Just to give you a perspective of the marketplace, in 2018, there were 1,500 LTC pharmacy locations nationwide. On average, those LTC pharmacies serviced about 1,500 to 3,000 beds or otherwise patients. and had between $5 and $15 million in prescription revenue and that filled between 11 and 13 prescriptions per patient per month. NCPA estimates the cost to dispense for LTC pharmacy is about 25% more than retail independent pharmacies. Additionally, LTC pharmacy spending has increased over the last 4 years. In 2014, it was a little over $4.8 million per location, and in 2018, that had jumped to $6.2 million. This increase is primarily due to emerging brands in the category, i.e. multiple sclerosis, and the other typical market shift in brand inflation, which we've all experienced. The main therapeutic categories in LTC are Alzheimer's dementia, anticoagulants, oral diabetic agents, insulins, respiratory inhalers, and atypical antipsychotics. I know this is probably hard to tell from this picture, but LTC pharmacies, pictured on the left, are different than retail combos. Example is on the right. Primarily, the LTC pharmacy is a production distribution model similar to our distribution facilities, whereas the retail combo is a smaller dedicated space, typically in the back of the pharmacy for processing prescriptions and deliveries. LTC closed door pharmacy versus the combo shop. On the left-hand side, we have a list of differences, and primarily there are differences and similarities between the two. On the LTC closed door, there is little or no signage outside. There's absolutely no walk-in traffic. They're often in a warehouse-type setting with a secured locked front entrance. The similarities are that they service long-term care facilities. They could be skilled, assisted living, mental health facilities, hospice, or correction facilities. And they also have a high adoption of automation in their pharmacy setup. They also only have one NCPDP taxonomy for long-term care pharmacy. The retail combo side is a traditional retail pharmacy with signage outside. They accept walk-in traffic and are not closed door. They service the same long-term care facilities in most cases, and they have a low to medium automation adoption for technology. Additionally, they are operating under their retail pharmacy NCPDP taxonomy, and in some cases, they have an additional one for long-term care. What are the opportunities for the retail combo for the pharmacy? From the top, first, the expanded customer access. Retail combo has the potential to expand your customer access to the aging customer base that is moving into these LTC settings in ALF or SNF settings. It is no surprise that these areas are growing with the aging of the U.S. population, referred to as the silver tsunami in some cases. This tsunami effect is the rapid growth of the boomer generation turning 65. As of 2020, it is estimated that 54 million people fall into the category of 65 or older, and that number will expand by 20 million by 2030. Additionally, there are some non-traditional care settings such as mental health and correction facilities in your areas. And lastly, the emergence of the at-home model. We're seeing more patients staying closer to home and being serviced from retail combo or from long-term care settings. Second, the increased reimbursement with access to LTC rates and reduced DIR fees for Med D plans if the 10 CMS guidelines are met. I want to be careful about the DIR fee reduction component. It is no secret these combo programs are being promoted since this reduction in DIR fees is having such a negative effect in the retail space. These reductions are limited to specific LTC patients and reimbursements. Pharmacies shouldn't only focus on this point when considering entering into a retail combo. They should be evaluating more about the patients that they're servicing and if they have met the CMS requirements. Third, increased cost of goods with branded only contracts. Currently, the GPO'S that we'll speak about later in the presentation, they manage between 5 and 25 manufacturers with an average of 1 to 5% savings on the branded products. These savings come in two forms. One is from off invoice, so where you see it on your paying at the pump when you order the product, or you could be receiving it from a manufacturer off rebate that is paid quarterly to the pharmacy. What is required to gain access to the combo programs? The bottom line is the retail pharmacy needs to service patients that are medically unable to come to the retail pharmacy and that are in the following care settings. That would be assisted living facilities, ALFs, skilled nursing facility, group personal care homes, correctional facilities, intermediate care facilities, hospice, independent living, or medical at home, developmentally disabled group homes, or chronic psychiatric facilities. What are the requirements to gain access to LTC combo programs? Additionally, we talked about the CMS guidelines to gain access to additional reimbursements for Med D plans. It is important to note, while these 10 guidelines need to be met, you don't have to do each of them in your pharmacy, but you will need to be able to provide these services. The comprehensive inventory and inventory capacity, the formulary listed drugs commonly used in LTC settings are easy to provide. Pharmacy operations, prescription orders, where you have to provide a drug utilization review, procedural manuals and training to the LTC staff, those are all provided by the pharmacy. Lastly, but specialty packaging or compliance packaging is required for these medications. Access or the ability to provide IV medications. This is an area that a lot of people feel like, well, I'm not going to do a combo because I don't have the facility to provide IV medications. This is where you can contract with somebody locally that can provide those medications for you. You need the ability to provide compounding or alternate forms of drug composition. Pharmacists need to be on call 24 hours a day, 7 days a week. Depending on the type of facility that you're providing, 24-hour, you need to provide this, but they may not require it as much as a higher acuity setting such as a SNF. You need to be able to provide emergency boxes or e-kits and emergency logbooks that go along with those, along with miscellaneous reporting, forms, and prescription ordering supplies. Who are the Retail LTC Combo GPO'S? I've listed out MHA, Innovatix, or a Premier Company, and GeriMed. These are the three primary GPO'S in the LTC space today. A lot of questions arise between the difference between a GPO and a buying group. Wanted to list out on the left-hand side the difference between a GPO and the right side, the difference of a buying group. GPOs negotiate prices with drug manufacturers on behalf of the pharmacies. They have a portfolio of contracted prices that are passed on to the members. These contract prices include both brand and generic products. The pharmacy still negotiates their agreement with the wholesaler, and they also provide such services as PSAO, reconciliation, reporting, and alternate care pharmacies. Buying groups negotiate buy plans with wholesalers on behalf of their members. So more of a collection of pharmacies negotiating with a wholesaler for a buy plan. They utilize wholesaler generic portfolios as part of their agreement, i.e. the AAP source portfolio. They structure deals for individual pharmacies and pharmacy groups that have common ownership. They also provide services as retail PSAO, reconciliation services, and reporting for retail pharmacies as well. As I stated earlier, the group organizations that we see predominantly in the LTC space today are GeriMed, Managed Health Care Associates, MHA, Innovatix, which is now being rebranded as Premier. Some of you may be familiar with Premier as a predominantly acute care GPO. They merged with Innovatix and now they're rebranding. The services that they provide, and I think are really important for customers to evaluate when they're deciding on which GPO to go with, is the industry expertise that they provide. These GPOs are very entrenched into the LTC marketplace in and around the country. They understand the customers that you're going to be providing services to and can help you really grow that business or help you navigate the waters of providing those services. They provide manufacturer contracts from a purchasing standpoint that help you get incremental margin there. They provide PSAO support if needed for the long-term care contracts. They also have marketing information for you to grow this segment. They can provide sample contracting of what the contract looks like if you're going to enter into a contract with an ALF or SNF. And they also provide additional pharmacy system or reimbursement services depending on who you go with. What are the third-party contracting options for a combo pharmacy? One of the points that I'd like to point out is the need for the GPO PSAO services. In some cases, depending on the size of the patient population that you're providing, it is not a requirement that you need to have alignment with a long-term care GPO for their PSAO services. And the reason why I state that is the retail PSAOs listed here, LeaderNet, MS Internet, Arete, PPOK, that you are all familiar with, also provide additional LTC contracting that you can access without any additional cost. Basically, you would need to fill out that attestation required for this to access these additional LTC services. The long-term care GPO PSAOs will require you to have a separate NPI and CPDP credentialing. The pharmacy should evaluate these PSAO services for their contracting rates, and these are rates that the GPO would be able to provide when you're doing your evaluation with them. Additionally, your pharmacist system is going to need to be able to be partitioned so that it can handle the additional NPI and CPDP number for billing. I wanted to get a little bit perspective of the Medicare Part D combo show by the numbers for LeaderNet and MS Internet. I'm not trying to represent these, but to just give you more background of what the programs offer. Currently, there are 14 PBMs in the LeaderNet MS Internet contracts with MedD LTC networks. Each of these networks require the pharmacy be able to attest to the 10 CMS requirements. It generally takes about 2 months for the PBMs to recognize the LTC affiliation for a new member. So just be aware of that. It'll allow some time to set up this LTC combo program. Additionally, today, about 45% of all pharmacists provide LTC services to their patient in a retail setting. 457 LeaderNet and MS Internet pharmacies utilize Medicare Part D combo shop solution today. About 15,000 skilled nursing facilities are serviced with Medicare Part D covered stays in 2018. I wanted to take a moment to talk about manufacturing contract and what a chargeback is, since this is not something that is familiar in the retail class of trade. When we talk about the manufacturer contracting through a GPO where they contract for a price with a brand manufacturer, we at Cardinal, we'd load that manufacturer price based on the eligibility of the pharmacy and the enrollment from the GPO. The manufacturer sells that product to Cardinal at wholesale acquisition cost. We then sell that product to the pharmacy under the GPO contract, including the cost of goods. Once that sale has happened, then we report that back to the manufacturer to recoup the difference between wholesale acquisition and the GPO contracted price. So in this example, let's take an example of a branded drug that costs $100. And let's say the GPO has contracted with the manufacturer for a 5% discount. Well, that product would now be $95 less the cost of goods that the retail pharmacy is eligible for on the invoice. The wholesaler would then contact the manufacturer on behalf of that pharmacy and the GPO to be recouped for the additional $5 off of WAC, or the 5% off of WAC that was passed along on the GPO contract. The reason why this is important for the pharmacy to understand is in the aspect of if there is a chargeback denial. The chargeback denial is something that we don't know, the wholesaler doesn't know until after the product's been sold, gone through the same steps. We bought the product from the manufacturer at WAC. We've sold it to the pharmacy with the GPO contracted price, less the cost of goods. We had contacted the manufacturer for the additional reimbursement. It is denied based on the patient being serviced or not meeting the criteria of what the manufacturer has designated to access that pricing. In that case, the wholesaler then bills back the customer the difference, the discounted difference from the GPO price and the WAC. This is a chargeback denial. Just to recap and review kind of what we have covered here today, as a pharmacy customer, the considerations are these. Is your pharmacy servicing LTC patients that reside in an LTC setting today? Are they in ALF or SNF or other eligible locations? Is your pharmacy capable to fulfilling the 10 CMS requirements? This is really important that you are able to do this. GPO fees, you want to take into consideration. the GPOs, and we suggest that you evaluate each of the GPOs based on your pharmacy's needs. They are geared to do a full evaluation based on your prescriptions, the patients that you're servicing. They'll be able to take you through what those different manufacturer contracts are under their portfolio, help you evaluate that. They'll be able to evaluate their payer network based on the dispense information that you're able to provide. And at the same time, they'll be able to walk you through the different services that they offer that could be important to you and your business. Each one of these GPOs are different. We at Cardinal remain agnostic because we work with all three of them. We have great working relationships with each one. Each have their own structure on how they do. Some have a per transaction fee for accessing their PSAO. Others have a monthly flat fee. And you need to consider the fees when you're evaluating the GPO combo program. You want them to be specific about the savings that you're going to have. There's a lot of talk and discussion about the value of these contracts and what a pharmacy would expect from them. In our evaluation of it, the branded manufacturer contracts are very limited. There are very few, more and more, with everything transitioning from brand to generic products. And primarily your generics are coming through your AAP source or other source programs that drive the economics to your retail deal. Additionally, these savings, as we have evaluated, represent anywhere from 1% to possibly 5% on a small set of branded products. So you want to take this in consideration when you're evaluating any of the programs and any of the fees that are associated with joining these. Additionally, does your pharmacy have space to separate the inventory? When we talk to pharmacies, a best practice for this is that you have a designated shelf or space to store the GPO manufactured product that you have bought on contract. The last thing that you want to do is have any risk of an audit from the manufacturer coming by your pharmacy and that you're not able to identify easily the products that you have purchased under contract and that you're dispensing to these patients in these serviced homes. A lot of people have talked to us about, well, I can separate my inventory virtually. Will this work? I say, yes, it does, but it is really important that you consider it doesn't take a lot of space to separate the inventory, and it is very clear and distinct that you have a separate inventory of GPO content products, and is easily identifiable. You do not want to run the risk of dispensing one of these products to the wrong class of trade or to an ineligible person. This violates different safe harbor laws that would expose you to fines up to $25,000 per incident, up to and including jail time if it was presented that you were doing it in a fraudulent way. It's just not worth the risk, and it's easy to separate the inventory. Lastly, some other considerations, and we touched on these a little bit as we went through. The manufacturer chargeback is not something that you're seeing in a retail setting, but is a very real possibility that if you're not following the guidelines, that these can come back later on and come into your business and you're responsible for them. It is a risk that you want to make sure that you're working with your GPO partners to make sure that you're doing the proper service and accounting to minimize this risk. Additionally, you're getting into these and not meeting the criteria, then you open yourself up to PBM or payer audit risks as well. So you want to make sure that you're following the CMS guidelines to mitigate those. Lastly, I wanted to kind of provide at the end of this some links about the industry. One is the NCPA link to the LTC division. They're a great resource for additional help in how to manage these patients and service this industry. And another one that we are a part of is the SCPC Coalition, or Senior Care Pharmacy Coalition, listed here below. With that, I've actually gone a little faster in time, but Tracy, are there any questions?
Yeah, we actually have quite a few questions in the queue, Richard. So we'll just start at the top and work our way through them. So the first one is, how do we take advantage of the improved cost of goods with the LTC?
So first of all, to access this program, you would want to contact your PBC, and you're doing both of these steps kind of in parallel. First of all, you want to reach out to one of the 3 GPO partners that we have listed. You'll want to start that process and evaluation of what you're doing in your pharmacy. At the same time, you're going to want to contact your PBC because we have an enrollment form, and there is a an enrollment form that is attached to your retail member certification that we have on file, that you understand the responsibilities that we're going to load branded contracts, that you're going to be responsible for any kind of chargeback denials if they happen, and so on. So that is how, once you contact the GPO and get it set up with them, then you are going to set up with us, and that goes through our enrollment process. We set up a separate account for you to be able to access those. And it takes roughly about 30 days from the start of this process to up and going from an account setup. And it can take up to 45 days to have all the contracts that you're eligible to be attached.
Great, thank you. Next question, are you allowed to join more than one GPO?
There is not a rule against being associated to multiple GPOs, but I would really question the pharmacy to evaluate the value in doing that. Because what happens in these cases, if you're associated to 2 GPOs, it runs more of a risk of not accessing the correct contract, running a higher risk of manufacturer denials based on the dual reporting. So I would really hesitate, not that it's a rule that you can't, but I would hesitate that you would want to enter in a dual relationship, just because there's so much, I don't know if the value, additional value is there versus the risk, but you would have to evaluate it on an individual level.
Okay, thank you. Next one, do you only need a separate NPI if you go with a GPO?
No, the only reason why you need the NPI, the separate NPI/NCPDP number, is if you're going with a GPO that you're going to access their payer network. If you're going to still use your retail payer network for the LTC contracts, you do not need a separate NPI/NCPDP number. The only time that you will need a separate NPI/NCPDP number is if you're going to access the GPO's long-term care PSAO. It will cause a conflict with your original retail PSAO. In that case, you'll need the separate one.
Okay, thank you. Next one, do you need a minimum number of LTC patients to qualify for the combo shop?
There isn't a minimum from our perspective that you would need. You will want to evaluate the costs associated with the GPO with the revenue the additional revenue, basically doing an ROI on the business that you're going to service. Those are can be different for each person depending on what you're servicing and the patients that you have. So there's not a minimum per se. In some cases, I hear people say, oh, you have to have, 50 patients. But it is really about the patients that you have and the costs associated with the GPO.
Okay, thank you. Beyond the pharmacy system partitioning that you mentioned, are there any other technology considerations that a pharmacy would need to put in place to get started, such as an EMR?
Well, that depends on the home and facility that you're dealing with. There are going to be cases when you go out and try to service, you're not going to be able to just show up and service them. It really depends on the pharmacy or the home or facility that you're servicing and their requirements of what you're going to need. In some cases, you're going to need to be able to provide EMR. In some cases, you're going to be able to have to provide other accessories that they're accustomed to getting from, a traditional long-term care pharmacy.
Okay, thank you. Can you comment at all on any marketing considerations, steps that a pharmacy would take to attract or bid on business with a facility?
Yeah, I mean, there's, the one thing that I would, from a marketing standpoint, I would really contact some of your, and we can get you links to it, but it'll help you define what your marketplace is, how many assisted living facilities are in your area, skilled nursing facilities that are in your area. I would then kind of determine what your marketplace looks like. And you would want to determine, you'd want to go out and scout out these facilities and have conversations, build relationships with them to find out what they're going to be looking for. And when I say this is, these are most likely are being serviced by, larger independent LTC pharmacies, or they may be serviced by some of the larger LTC pharmacy chains. So your market may be more limited. But I would start with kind of understanding your demographics and marketplace from that standpoint. And then you can start building out your marketing plan as far as, are you going to be able to, what's your delivery radius that you're going to have? What types of packaging are you going to be able to provide? Are you going to provide one, or is there multiple? Do you have any kind of automation that they're looking for? But really, some of this is going to be, work that you have to do by going out to these facilities and kind of seeing what they're getting today and how they're being serviced. And then asking yourself, what are the services that you want to be able to provide inside your opportunity?
Okay, thank you. As a follow-up to that, do you have any marketing templates, or does Cardinal have any marketing templates that they could provide to assist with getting this business off the ground?
Originally we had a program several years back, and but that has been now really pushed more to our GPO partners. They do a very good job about understanding the marketplace and how pharmacies can market into this space. We've also done some individual contracting with NCPA and some of their folks as far as helping build some marketing templates for you to guide along with as well. There are also other industry resources. These two that I've listed here, NCPA and SCPC, are both very good areas to reach out for additional marketing help as well.
Lovely, thank you. Is there any pharmacy organization that provides a contract for IV meds or compounded meds if I'm unable to do those in my pharmacy?
There are. I don't have a reference for you, but we can get that information. But there's a lot of IV medication services that provide those outsourcing to the acute care facilities in your different areas, and we can reach out to those as well.
Okay, thank you. And the last one currently in the queue is, can you comment at all on the differences between retail and long-term care business from an average gross profit margin perspective?
Yeah, so when you look at long-term care closed door pharmacies average between 30 and 35% gross margin. And in retail independent, and depending on your pharmacy that you are today, you're probably more aware of the percentages, but it's more 18 to 22%. The reason LTC fully closed door, and you have to understand the margin rates on the combo programs will shift for additional margin in your retail setting. So you'll pick up incremental margin in either reimbursements or manufacturing contract, but it will not be as fully robust as a full closed door pharmacy. So if you're wanting to access that, that's a whole different conversation and commitment. But from a reference standpoint, LTC is between 30 and 35%, and retail independent is 18 to 22%, depending on the operator.
Okay, thank you. That wraps up the questions in the queue. So wanted to say thank you, Richard, for sharing your expertise with us. We sincerely appreciate your support of AAP and of Independent Community Pharmacy. And again, thank you to BestRx for their generous financial contribution to today's presentation. As a reminder, to obtain